thanks for joining us again. I'm Scott Murray. I'm a consultant cardiologist in Liverpool. I'm interested in preventing heart attacks. I've got with me two of my colleagues who are going to introduce themselves. And the aim of this podcast is to give you some idea of how we think and how we try and project things to patients to try and give them the best information to try and stop them from having a heart attack. So, Tom.
Hi, Tom Heseltine, consultant cardiologist. Interested in prevention of heart disease and heart attacks, and also an interest in cardiac imaging.
Good afternoon. My name's John Hung. Too formal this time. Too formal.
No.
I'm John Hung. I'm an interventional cardiologist, and like the other two here, I am very interested in cardiac health, risk prevention, but I also meet patients at the sharp end when they sometimes need a coronary intervention. So I'd really like to prevent that just as much.
Yeah, less business for you, but you could sleep longer, I suppose. You don't have to get up.
If people don't come in as emergencies, I can sleep longer, you mean?
Yeah.
Yeah, no one likes getting woken up at 4 a.m.
Yeah.
How often are you getting woken up these days? Nightly?
Well, to give you an idea, if I'm on call for primary PCI, that means if I'm the doctor on call for heart attacks to do the stents, we serve a population of about 3 million. And on average, in a 24-hour period, we get about 5 primary PCI activations, and 3 of those are likely to be overnight. Yeah. So there are some nights when I don't get called, but they are few and far between. And on most nights, I'll get called at least once, usually twice. And that can be obviously at any time, you know. There's been nights when I've been called 8 times. Wow. It's, it's variable.
Yeah, so if we can do anything, keeping you asleep is probably one of the goals of this podcast.
I'd be very grateful. Although I do have a 6-year-old daughter who spends most of the evening kicking me in the nuts.
All right, okay.
So it might not actually feel the benefit, to be quite honest.
Yeah. To pull it back in, so this is number 2 of number 2. He's started chuckling already. It's like it's just impossible. This is the second podcast. In the first one, we sort of in the number 1, we tinkled our way through what the introductions of how you develop heart disease and what we sort of see day to day. I think we'll probably hone in on risk factors in this episode and how early the risk factors can start and how early disease can start. So I'll probably kick it off by saying, we know that in familial hyperlipidemia, like homozygous FH, they've fetuses who may not survive, when they did autopsies on them, they found fatty streaks.
Is that right?
Yeah, apparently so. And then obviously there are some, like you said, you've stented a 28-year-old who had familial hypercholesterolemia. So why don't we start with lipids and that sort of area, try and explain things of FH and different versions of that. Is that fair to say?
Yeah.
I mean, you might want to take it from how you start to get lipid elevations that are...
Yeah.
What's a lipid, Tom?
Oh, yeah, so...
Well, so lipids, what we generally mean by that is your cholesterol metrics, or the different, blood tests that we do to measure the different parameters of cholesterol. And it's really complicated, and we're only scratching the surface of this. So I think it's probably best that we don't sort of go deep dive. To be honest, I don't understand all of it. I'm not a lipidologist by training, because there's specific doctors that specialize just in this field.
We should probably just do one on lipids because it is quite...
Yeah, so it's a really sort of, deep and complex topic. But, to keep it simple, when you go to your GP and they do a lipid blood test, it's usually measuring certain parameters. You get different things depending on what what blood test, but generally speaking, it includes a total cholesterol. It includes something called HDL cholesterol, which is thought of, I don't know if we're still describing it as this or not, but the good cholesterol, LDL cholesterol, which is the bad cholesterol, and then non-HDL cholesterol, which is a combination of all of the remnant cholesterol, LDL cholesterol. So basically, everything that's not HDL. And the reason we do that, I think, is it's historical now, kind of. We used to measure different parts of it. So back in the 90s, I think, you'll probably correct me if I'm wrong here, but we used to sort of total cholesterol was a thing that we targeted. Things have moved on a bit recently. We now sort of target LDL cholesterol, the bad cholesterol. So those are generally the things that we measure. I don't know if you want to add anything to that.
No, I'm just going to ask you another question. So is having high cholesterol bad?
Well, that's where it gets really interesting. So I think it's probably best that we sort of talk a little bit about how cholesterol's made, how it's synthesized, and then go on from there.
Yeah. I mean, I probably would just say right away, there are no good and bad cholesterols. It's the same thing. Yeah.
That's why we're sort of chuckling a bit when we're saying it.
Yeah. So that's something, if anybody's watching who is a GP or is a patient or is anything, we should stop that right now about
Stop saying good and bad.
Yeah.
It's interesting though, because it's very difficult to do that, because you sort of say LDL cholesterol to a patient and they'll go, they don't get it.
Listen, treat me as a patient, right? Because I'm a simple interventional cardiologist. So when you said you're going to do a deep dive on the lipids, I thought, I better, I'll be listening a lot for that episode. But in my simple understanding, we like it when you've got a high HDL, but we don't like it when you've got a high LDL. So why is it not that there's a good and a bad cholesterol?
I think the simple answer is we should probably just discard telling patients what their HDL cholesterol is, because it's kind of meaningless. And I'd probably say that because it's so complicated that in actual fact, telling them it might give them a false reassurance that there's something good about it. And it's like, oh, your LDL's 4.5, but your HDL's 2. And that is really good. You're golden. Don't worry. You've got really high good cholesterol. And someone goes away, oh yeah, I've got really good high cholesterol. No. It's so much more complex than that. And I think if you're framing it to patients and you want to simplify it down, it's probably better just to focus on non-HDL cholesterol. So the totality of the lipids that are not in HDL, rather, because that gives you all of your bad cholesterol, and then you can just focus on bad and say, for us as medics, we know your LDLs, your VLDLs, your lipoprotein, little a's, your remnants, all of that is contained within that metric. And that's why GPs switched to that a little while ago, saying, don't fast for your blood test, just come in and we'll do your non-HDL and that'll give us an idea. There's probably a decent argument in that, but then you don't get triglycerides if you don't fast, or the triglycerides are raised because you had some Weetabix or whatever. So I think it is complicated. It probably needs another episode, but if we just state for now that lipids are very, very important, and unless you're the smoking granny who can do chin-ups at 90 and doesn't have lung cancer, then it matters in terms of your progression and development of coronary artery disease.
I'd just like to frame it, how cholesterol is a risk factor and how it, traditionally is thought of as a risk factor. Because I think I was taught at medical school anyway is probably what patients intuitively think about it. So, the common thought about cholesterol and how it, causes atherosclerosis.
Fat clogs up your arteries.
Yeah, exactly. So the common thought is that, and, there's still evidence for this, is that, LDL cholesterol, i.e. the bad cholesterol.
You're not allowed to say that anymore.
No, sorry.
The host has already told you that.
It's my last time.
Can we have Tom Heseltine removed from the podcast
debut
studio?
and last
Please?
podcast, thank you.
Any more mention of good or bad?
So LDL cholesterol.
Yellow card. Sorry, go on.
LDL cholesterol crosses the vascular bed, so the endothelium, in the coronary arteries, and embeds itself within the layer between the endothelium and the smooth muscle, the intima within the artery. And that causes attraction of inflammatory cells. And the higher that LDL cholesterol, the more at risk you are from developing atherosclerosis and heart attacks. And the sort of flip side of that is HDL pulls that LDL cholesterol out of the artery. And, that was how I was educated.
Yeah.
The reality of that is we know that is not the case now, and it's far more complex and
yeah.
intricate. But as a general rule of thumb, that's probably what most people understand about cholesterol. So having high cholesterol is, is bad. It depends on your population that you're looking at.
Context matters. So if we're smashing myths here, does fat clog up the arteries, John?
No.
Okay. It doesn't get into. I mean, people I think you chug some cream, it goes into your arteries, and then it's.
And on that point, patients still come in and say, "It's all right. I'm eating a low fat diet."
Oh Christ, we're going to get into diet here.
No, let's
look, I think that the public health campaigns that showed pictures of arteries being clogged up with fat were not terrible. It's the right intention, and we do need to be well educated on diet and nutrition, and that's probably one of the main things that will come out of our conversations. But no, eating fat per se doesn't clog up your arteries. In fact, I might expose my own lack of knowledge here, but most of the lipid particles in your blood are not ingested. That's true, isn't it?
Yep.
Most of it is made in your liver, right?
You're making ApoB100 in your liver, and you're absorbing ApoB48 through your gut.
So what percentage of your lipid particles in your bloodstream are actually eaten in the form of cheeseburgers?
Well, I mean, I suppose it's like you eat a cheeseburger, it all gets mushed up. Your small bowel eventually sucks all that stuff in and starts partitioning it. You will, in your bowels, eventually the particle that is prominent there is a chylomicron. So that's like a big particle that's full of triglyceride. Once that is sort of there, I mean, from a liver perspective, the alternate particle is the VLDL, which is a big particle. It's got loads of triglyceride in it and doesn't have a lot of cholesterol in it. Let's not go down this rabbit hole because it'll take too long. But ultimately, I think where I was trying to move things was less away from the fat that you're eating and the fat that you've got stored on your body. And I think that's where actually the message was good, but sort of if we could switch that message to be how fat you are is more important than the fat that you're eating, and especially where that fat is stored. And I think that's probably where we could go over to Tom about what you've seen in the HIV model of atherosclerosis and how you can maybe explain why we studied that population.
Yeah, 100%. So I think, just another sort of comment on, cheeseburgers causing fat. Most of the fat that you synthesize is de novo lipogenesis, isn't it? Which is from overconsumption of carbohydrate and glucose
Sugar
and fructose and that kind of thing. So just to sort of clarify that point, it's not eating fat cheeseburgers, it's overnutrition. So it's overconsumption.
Over your calorie balance.
Yeah, exactly.
Is a bad thing
excessive
to do,
caloric intake. So excess, calories in the form of carbohydrate, predominantly in Western civilizations. Protein, if you to chug 20 protein shakes a day, or and fat if you are eating cheeseburgers. So it's not just the fat.
So what if I just ate eggs?
Yeah, no, that's a great
question.
So
what if I just ate 20 eggs a day for the next month? What would happen to my cholesterol?
It would skyrocket because you're consuming a huge amount of cholesterol in the egg yolk, and probably what would happen is you downregulate your LDL receptors, and because your liver would be saying we don't need any more cholesterol coming in here, your liver would be getting sense to say stop making receptors to bring more fat in because I'm getting fatty here.
You're getting lipotoxic.
Yeah. So I mean, all this sensational stuff on the internet about eating 20 eggs and my cholesterol didn't move, and then I ate some Oreos and my cholesterol plummeted. I mean, that's just for clicks, let's be honest, and that's just to try and generate some revenue on videos, which is a borderline sort of unethical, I think. I don't think we should be doing the sensational stuff, and that's the whole part of why we're doing this, is the truths of what we see day to day. You should not be chugging 20 eggs a day. You should not be chugging cream, but similarly, you should not be mainlining, I had a woman who used to spoon sugar in. Like she used to had a bag of sugar and she would actually spoon sugar into her mouth.
Spoonful of sugar.
Coronary artery's normal.
There you go.
Yeah. So it's like another one of those things.
Carry on with your silver spoon.
I've got a woman whose cholesterol is 20. Her LDL is 13. It's been like that for 10 years. Coronary artery's normal.
Is that someone on a keto diet?
Yeah, so someone just ribeyes and butter and exercise and very skinny, a lean mass, whatever. You know, we can talk about that later.
An LMHR.
Yeah, that term that's been generated by, a sort of group of people. Yeah. But again, it's your smoking granny doing chin-ups.
Yeah.
So,
so if we want to sort of summarize the cholesterol thing, you've made it clear to me that there is no good and bad cholesterol.
Yeah.
It's probably bad to have a high LDL or exposure to high LDL for any period of time. So if I was a patient, what can I do about that? If I want to check that or manage that, what options have I got?
Get tested.
Yeah, and it's really tough, isn't it? And I think you got to looking at cholesterol in isolation. It's very difficult to do that and understand anything about it. If for example, your father had a heart attack age 40 and he had high cholesterol, and you go to your GP and lo and behold, you've got super high cholesterol, then you need something looking at. You need to think about aggressive, either we can talk about CT scanning or but certainly look at lowering your cholesterol. But it's looking at you as an individual, because if you look at someone who's got a lean mass of just no fat on them, who is exercising loads and they're eating a ketogenic diet and they've got an LDL of 6, that's very different from someone who's 60, has a BMI of 45 and just having chippy tea every other night.
Yeah.
But does your lean person with the high muscle mass who's got an LDL of 6, is that all right then?
Well, no, not always. So this is where it gets really complicated and really interesting for me. And we sort of strayed away slightly from the topic. We were going to talk about HIV, but it's all to do with, we can delve into it, but it's all to do for me with your energy metabolism and how well you store energy as an individual.
Yeah.
And there's certain ways in which, you can store excess energy, so fat, in a safe and effective way. And that is a lot to do with your genetics. And I think that's a major contributor of that genetic risk, how well you store fat. Western civilizations were over-consuming calories, as we've already talked about. Adverts, it's so easy to get Deliveroo, chippy tea, convenience food. It's all marketed at you. It's all palatable. It's all, high energy, high calories, and, full of crap. And so the Western population is overweight, but it's how you store that. And that's how it influences your risk and, vascular biology for you as an individual.
Where do you store your fat, Scott?
On my arse cheeks.
Which is a safe way.
Very safe.
Gynoid fat distribution. I think it's more important about whether you've got fat on your organs, and that's the nasty visceral fat that we could probably step into. But I think if we're rounding this off, it would be not so much good and bad cholesterol, and not so much it's the fat that you're ingesting rather than the fat that you're storing, and where you're storing it is important. And we can go deeper into that. Just to ask you, John, about what if you had to do a social demographic on your punter that lands on the table, we'll end this podcast on a sort of what you see when people come in. Are you seeing big fat diabetics, or are you seeing skinny exercise butter freaks? What are you seeing? I'm
going to give you a professional answer, Scott. The commonest risk factor profile I see, which I write down 25 times a week, is hypertensive, overweight, type 2 diabetes, hypercholesterolemia.
Fatty liver?
They will do.
Well, if we paid attention to that more, then I think we would see that. But I've just described metabolic syndrome basically, but that is by far and away the commonest risk factor profile that I see. In terms of the LMHRs or your ketogenic people who've got big LDLs. To be honest, not at the minute. But, you know, this is kind of a new phenomenon, so let's give it some time. But yeah, if you work in a cardiac catheter lab like I do, nearly all the patients have some constellation of those risk factors.
An abdominal girth.
Yeah, so if I give you the less professional answer, it's a fat middle-aged man who drives for a living.
Right.
That's pretty, you know, that's because people,
Sedentary behaviour.
It's sedentary. The access to good food is more difficult.
On the fly, they're having like, meal deal lunch.
Have you ever tried to get something good to eat at a service station?
No.
Do you know what I mean?
You can't.
You have to go to M&S Food and spend £8 on a couple of chicken fillets. It's really hard. So, you know, there's my sympathy.
That's the weekly budget gone.
That's it.
100%.
So that's it. And obviously being a man probably is a risk factor as well.
Being a man, getting older, the things you can't change, we're all sat here. Yeah. So I suppose in a way, we should probably then next podcast talk about walking backwards from, I think it's called Rewinding the Future. So you take your middle-aged man who's sedentary with abdominal girth, hypertension, diabetes, fatty liver, high cholesterol, all those things, and we probably walk backwards from there and say, actually, what happened to him as a teenager that caused that progression, and we could probably walk through that. I think
it's important as well just to sort of differentiate the different genetics with this, because if you've got an individual from South Asia, for example, we're talking about people who are overweight here. You don't necessarily need to be overweight in terms of abdominal girth to generate metabolic syndrome. You know, particularly when we're thinking about South Asian populations, you know, they just have to look at a Mars bar the wrong way, and you know, they've got very little in terms of abdominal fat.
No storage capacity yet.
And
all
they've
visceral
got
fat.
Raging diabetes.
Raging hypercholesterolemia.
Yeah, hypercholesterolemia, hypertension. And they end up on the cath lab table just the same as someone that's, you know, got a BMI of 40 or whatever.
Yeah.
So that also, you know, segues into why BMI isn't necessarily such a great tool as well. And
why we are going to obviously advocate that if you are in that ballpark and you've got the genetics and you think, well, that sounds a bit like me, that you should go and get tested, get your blood pressure done, get your lipids checked, get a CT scan, or at least advocate for a scan of your arteries so that you know where you currently at. I mean, we've had patients come through that we all know who had really no symptoms, maybe a mild feeling that they were slightly feeling of an impending something not quite right, and then end up having a stent and when we actually, you know, your intervention, John, has hopefully prevented them from ultimately closing important arteries. Can I ask you a question on that, John? Because when I was sort of going through a little bit of interventional training that I did, and I think we've talked about this in the past, where do you stand on sort of putting a stent in an artery that might be narrowed in a plaque sealing perspective, in terms of, you know, crushing that plaque to the side and preventing heart attacks? Because historically, I was always, you know, told that isn't a thing. What's your thoughts on that? Putting a stent in.
John takes a deep breath.
How long have we got?
One of the first meetings I went to was as a registrar when I was working with Scott on this, and that was about vulnerable plaques, and that really struck me at the time. You know, for the listener who doesn't know what that intuitively means, a vulnerable plaque is one of those thickenings of the coronary artery where the lipid particles there are inflammatory cells, there are invasive smooth muscle cells, and there's a pool. There's a lipid pool in the middle that's sitting in the wall of the artery. And what's preventing that from getting into the middle of the artery and blocking it is what we call a fibrous cap. That's the layer of cells that sits between the lipid pool and we call it a lumen, the center of the artery. And a vulnerable plaque is one which is at risk of rupturing. And the features that we've identified over the years that make a plaque vulnerable are if the fibrous cap happens to be thin, if there is already some microcalcification in it, and if there's a large lipid pool. So it makes perfect sense that if you've got a vulnerable plaque, why don't you just stent it now and then prevent it from rupturing someday and causing you a cardiac event? The thing that's difficult about that is that we don't know which ones are going to rupture. And there are definitely lots and lots of vulnerable plaques in people's arteries that will never rupture. Or they'll rupture subclinically and never cause you a problem. Now, the trouble with putting metalwork into arteries is that it has its downsides and stents can fail. The latest data we have suggests that probably in all comer populations, a stent's got about 5 to 7% chance of failing over 5 years. Now, obviously, none of my stents ever fail, but if you take in the whole population, that's roughly the risk of it. So, putting stents in isn't always the right answer. And that's a point of disappointment for many people who end up in the cath lab because they think they're going to go and get a stent and it's going to sort all their problems out. And that's, there really isn't a quick fix for this sort of thing. So to sort of answer your question, it may be a thing. Now, our current practice is that we don't plaque seal. We don't stent vulnerable plaques that are not otherwise flow limiting because we don't have the evidence to suggest that works overall. Now, it might prevent the heart attack that plaque could have caused, but also there will be events downstream in terms of the stents failing and then having an event associated with it. So we don't do it at the moment, but we need to know more because there may be ways of telling which one of those vulnerable plaques is going to rupture and cause a heart attack. And of course, that is desirable. If you can work out which vulnerable plaque is going to cause a heart attack in which patient, it sounds like a good idea to stent it and prevent that from happening. But that's an area of ongoing research, and people have been looking for a long time for biomarkers which can pick these out. Also features on intracoronary imaging. We use various techniques to look at the artery from the inside in great detail. And we've already, the factors I said, thin fibrous cap, big lipid pools, we already know certain things which are predictive. There was a study that was published relatively recently, forget the name, Prevent.
Oh yeah.
And that showed a reduction in the primary endpoint for plaque sealing. But if, like any research, if you go into the fine detail, it's not quite
the devil's
as
in the
simple as
detail.
that. Yeah. So I think it's a really interesting area. It's an area I'm interested in. I think in the future we may be able to define which plaques we ought to seal, but at the moment I think it's probably an oversimplification to say that that's a good thing to do for everybody.
Vulnerable plaque versus vulnerable patient.
Yeah, vulnerable patient. That's what I switched to. So I think we're running out of time here for today. So I'd just like to thank everyone for joining us. We're obviously on a journey here. We will walk through how you get towards a heart attack, and in the same realm, tell you how to hopefully prevent having a heart attack over the next few episodes. So thanks again to John and to Tom, and thank you for listening.